I want Dr. Abhijit Paul to be on the stage for moderate the session. And our medical director and chief anesthesia, Dr. Srinivas, sir, also to comment. Yeah, now coming to that session number 7 is the telemedicine, ER triage, and tele ICU and tele stroke, and other tele ambulance services. To speak on this, we have Dr. Silpa Chaudhary. Over to you, ma'am.
Thank you, sir. So now I am going to show you how we are doing our telemonitoring services in ICU, ER and ambulance. So teleconsultation, it's nothing but interaction that happen between a clinician and patient for the purpose of providing diagnostic and therapeutic advice through electronic means. So what it serves, the goal of telemedicine is to omit geographical and functional distance between two or more geographically separated healthcare providers. So what are all the benefits of telemedicine to the patients? So they can access to a specialized healthcare services to a underserved rural, semi-urban and remote areas. And they can access to a expertise of medical specialists to a larger population without any physical referral. And it will reduce the visits to a specialty hospitals, especially those who are having long-term follow-ups and those patients who are terminally ill. And what are all the benefits to the physicians? So it improves the diagnosis and better management and access to a computerized comprehensive data of the patients offline as well as real time, quick and timely follow-up of the patients discharged after a palliative care or long-term follow-up of the patients, and we can continuing the education and training through a video conferencing periodically. So now I am going to show how we are managing in Ramesh Hospital. So we are having a central command station located in Vijayawada. From Vijayawada, we are monitoring Vijayawada, Guntur and Ongole. All the 3 branches, we are having a telemonitoring services. Through that, I'll show you a small video showing our central command station. So this is our central command station from which we are monitoring all the 3 branches, Vijayawada, Guntur and Ongole. So, and we are having a video facility also. So through video we can see the patients also directly. In all 3 branches, critical areas like ICUs, ER and even ambulance also we are monitoring the patients. So in our central command station there will be one trained nurse and one doctor also will be there. So 24/7 they will monitor the patients who are all connected to our telemonitoring services. So you can see on the left side how we are monitoring through the cameras, and this side we are seeing the patient's vital data. So on each, this one there will be a display from which patient we are monitoring, and patient name, bed number, everything will be displayed. This is how patient's vital data will be displayed on the monitor. We'll have a ECG, pulse rate, saturation, everything, and we can see the data also. We can see the 24 hours data of the patient also in case of doubt. So it will display the area, bed number, everything, it will be displayed on the monitor. So this is the ICU. Through camera we can monitor the patients also. And this one is the ambulance. So we are monitoring the patients while transporting from one hospital to our hospital in the ambulance. This is how various areas we are monitoring through cameras. So after monitoring, if there is any important data or any critical event that is happening to a patient, we will alert a tele-alert. So we will inform the respective area through a call or through a speaker. So this is they are alerting a tele-alert. I think audio is not playing. They're alerting the respective area because patient is having tachyarrhythmia. So the respective area they're calling and they're giving an alert, so that they will inform the respective area sister and doctor. This is the speaker which we are having in all critical areas. So through that speaker they will directly give the alert saying that patient is having tachyarrhythmias, or if the patient is having any desaturation, they'll say so and so patient is having so and so bed number patient is having desaturation. So they will alert in a speaker in a respective areas directly from the telemonitoring station. So these are all few examples which they have given the tele alerts. When patient is having MI, here patient is having a desaturation, bradycardia, even patient is having VT. So all these are some of the examples of tele alerts which they have identified early, and they have given the alerts to the respected areas. So and this is the data how we will monitor our tele alerts. So they will document the data, patient name, everything, when they have given the alert and what action the respected areas doctors has taken also they will document, and we will audit this data. And the last patient we have seen having they have alerted VT. So that patient they are doing CPR. So through telemonitoring we can see the quality of the CPR also, how they are doing, is there any lags, or if they are having any help also they will provide through telemonitoring. And this is a tele-ambulance. This patient had RTA. On the scene itself, they have intubated the patient and they are transporting the patient from that scene to our hospital. So in the ambulance, we are monitoring the patient. So here we can see the patient, and the monitor which the patient has connected also, we can see all the patient vitals in our tele-ICU monitor. So vitals also we can see, and we can see the patient also directly. This is one more patient which they are doing CPR in the ER, emergency room. So this is our Guntur emergency room. So they are performing a CPR on patient who brought in an unresponsive state. So here also we can monitor the patient, especially if there is any mass casualties or if there is any rush in the casualty. If the ER physicians are busy in resuscitating some patients, if any unwanted event happened in the other patients, so we can monitor those patients and we can offer them more help, and we can alert in cases of necessary. So what are all the services we are doing in our hospital? We are having tele-ER, tele-ICU, tele-ambulance, home care, and even tele-stroke facilities are also available. We have given many stroke consultations through telemedicine, and 3 patients we have thrombolized through tele-stroke also. So what are all the things tele-ICU cannot solve? So especially for doing procedures and emergencies, one doctor will be needed in that place, because from here through telemedicine we can only give advice, because from here we cannot perform procedures. So a doctor will be needed for doing the procedures and during emergencies. And the patient feel of touch and especially clinical examination may be lacking in a telemedicine services. So what are all the advantages of tele-ICU? There will be a 24/7 availability of specialized critical care team to manage the emergencies. Especially patients can get treated in their peripheral setups only, decreasing overall cost of the healthcare team, and we can avoid the untoward effects or adverse effects which are happening during the transport of the patient. And access to the world-class critical care team facilities in their district hospitals we can provide, and we can provide cost-effective and affordable treatment. So this technology enables the physician to treat more patients within their same hospital manpower. So what are all the benefits? This is one of the article published in JAMA in 2011 saying how tele-ICU will help in improving the patient's care. In this they have studied patients before tele-ICU and after tele-ICU, and they have monitored the outcomes of the patient. So with the tele-ICU services, they have shown that there is 20% decrease in the mortality and 30% decrease in length of stay of the patients, and as much as 80% reduction in the complications through our tele-ICU services. Basically, tele-ICU services, they will provide an extra eye for monitoring the patient. So bedside nurses or bedside doctors, they will do a monitoring, but sometimes they may miss the events. So in those situations, through tele-ICU monitoring, we can identify the events early and we can prevent the complications. Thereby, we can reduce the mortality and length of stay also. So we have started Tele 4G Smart Ambulance. These are all some of the pictures of our Tele 4G ambulance pictures. So in this we are having all the facilities including ventilator, camera, and we are, as I shown you in my video, so we are having a tele monitoring service of the ambulance. So we have started Smart 4G Ambulance. So this is some of the data which we have given the tele-consultations. Starting way back from 2014 to till now, almost more than 1,57,000 tele-consultations we have given, which includes free tele-ECG consultations are also there. And through tele-ICU consultations, we have given some of the admissions also. From 2014 to till now, through tele-consultations, the total number of admissions are around 50,000. Thank you.
Thank you, Dr. Shilpa, for elaborating our tele services and tele ICU and tele ER and the future what we are launching the tele 4G ambulance. I request moderators if anything you can add to improve our telemedicine services, any other areas you require that we can include in our tele ICU services, telemedicine services.
Yeah, thank you, Shilpa, for a very, very comprehensive and complete overview of the tele ICU. It's actually in the last budget session, the Government of India promoted telehealth. But what I see with the Ramesh Hospital is you have gone much beyond what the government envisaged. So when I was here about a couple of years back, that time this was just starting off, the tele ICU. But what I see is that it has been taken much, much further, and you have even got the tele and the continuity of care even in the ambulance services, which is really, really remarkable to see. As you rightly told, one thought which I always have is the person on the ground. That always becomes a problem. Like when we monitor anybody from a remote facility, we always think that this gentleman could have done well with a central line, could have done with a more closed arterial line so that we could see the arterial pressure trace, could have done a little better with a flow track probably. So all those invasiveness sometimes becomes a problem when we kind of want to monitor a patient from far. Another thing, as you rightly just showed, the two CPR that they were giving, one was in the ER and one was in tele ICU. It's very, very important to train the doctor on ground on the ACLS and BLS so that they recognize the cardiac arrhythmias, they recognize the high quality CPR, chest compression, and of course that will of course change the outcome in a huge way. So these were the two thoughts which, otherwise it was a wonderful presentation. I think you're doing a great work, and I wish you all the best and the entire team of Ramesh Hospitals. Please stick to it, and probably we'll see much more in the future to come.
Thank you, sir.
Thank you.
Congratulations, Shilpa. You have done a good job. You can help people like us who keep patients tele ICU. So if there is any patient in our ICU, we feel patient is stabilized and doing well. All of a sudden, sometimes we may miss the issues like the things. Is it possible to help in tele ICU services to our hospital in our
Yes,
place?
sir. Yes, sir.
So
We are
that
planning-
already that facility is going on through your
At
service?
present, we are doing our inter-hospital monitoring only, sir, but in future, we are planning to expand to other hospitals also, sir.
Yeah, thank you.
Yes.
One more thing I wanted to add is nowadays there are many ultrasound image-guided courses which are going on. Maybe when we train those doctors on the site to do imaging of, say, cardiac echo, fast, and all of those, maybe it will even bring down the mortality, which you really showed the mortality being brought down to 20%, or as an international data. Probably it will be even better if you can detect a lot of things through the imaging techniques.
Yes, sir, definitely.
Hello, presented very nicely, Amma. This tele ICC is definitely a novel approach in treating the patients. But in my opinion, totally instead of depending upon tele ICCU, the physical appearance and assurance of the treating doctor or physician is also important, at least once in a day, instead of entirely depending upon the tele ICC.
Sir, this is only an extra eye only, sir.
Yeah, this is only extra
Physically,
benefit.
one person will be there definitely. Here from the tele ICU, we will give an extra effort or extra advice if they need anything.
Okay.
Somebody
Otherwise-
has to be there physically.
Yeah. Otherwise, the patient may feel that he is left alone.
Yes, sir.
and he
Somebody
is
has to be there
not being-
physically. From here, we are giving an extra support to them.
Yeah.
Ramesh Hospital setting so many telemedical centers, it is a boon for the rural people mainly. They in the midnight, if they have any suspicion of heart attack, they can't come to the center. So they can attend the peripheral centers and take the ECG immediately. They can consult and they can have the treatment, and it will help in the reduction of the mortality and also avoidance of the fear. If ECG is normal at that night, if you tell, they will feel so much relaxed also. So for diagnosis of the MI and for exclusion of the heart attack, and also for even elderly people also, they may not come, the distance can be covered, and the cost of the treatment also can be reduced. In the peripheral centers, monitoring, if doctors are there, we can come in contact with them and we can advise the treatment also, early thrombolysis or early shifting, or so that the mortality can be reduced.
Srinivas sir, you want to add anything to it? Yeah, thank you, Shilpa. So I would like to take this opportunity, as Dr. Ramesh sir also previously mentioned, to all the physicians who came from the periphery. If you have any difficulty in interpreting the ECGs, so use our telemedicine centers. We are there available for 24 hours so that we can pick up this MIs early and we can channelize them for early thrombolysis or PCI. Thank you very much.
Thank you.
So that concludes the session and we are moving on to the next session. I request the panelists and moderators to stay back here for the next session also. And I would like to ask the other panelists and moderators also to join the session. I request Dr. Kirtika Chaudhary to join the session, and Dr. M. Butchbabu for somewhere around here, and Dr. Prudvi Naresh, Dr. Potumuri Srinivasa Rao, Dr. M. Praveen, Dr. Pri Srinivasa Rao, and Dr. Prudvi, and moderators Dr. Vanajakshama Madam, Dr. David Chase, and Dr. Biju Govind, and Dr. C.S. Srinivasa Raj for somewhere around here. Sir, please come and join to moderate this session. So, and for the previous sessions, I ask Dr. Srinivas Prasad sir to hand over momentous to the moderators and panelists. So, next session will be an interesting session. It will be on the syncope and palpitations, when to worry. So, to give a lecture on this, we have two eminent speakers, Dr. M. Chandramouli, our electrophysiologist, and Dr. Nagasri Harita. So, first I would like to call upon Dr. M. Chandramouli to start the session. Syncope and palpitations, when to worry.
Good evening, everyone. First of all, at the outset, I would like to thank the organizers for giving me this opportunity. In this session, I am going to discuss about one of the common causes of syncope and palpitations.
Sir, voice is not clear, sir. Let me adjust the mic.
Okay.
Volume is not clear.
Okay.
Yes, I
Now
think
can
better
you
to
hear?
take- no, it's-
Yeah, okay. So this session is regarding the syncope and palpitations and one to worry. So I am going to just basically present 4 case scenarios. And in that case scenarios, I am going to present one of the common causes of syncope and palpitations, that is an ectopy, PVCs. How to deal with the patients who presents with PVCs. So in these scenarios, I try to deal with different types of case presentations. So the first thing is, the first scenario is like a 22-year male patient who presented with to the OPD and was referred here by a surgeon for a surgical fitness. So this is his ECG. So how do you approach?
So 22 years male, posted for an orthopedic surgery. So this is the ECG, so how to approach?
So, so basically, this is a common scenario what we come across in our regular OPD. Like patient will be referred for a surgical fitness. So ECG may be showing some ectopics. So how to deal with the patients? What are the things we need to do? What are the investigations? Like what investigations we can do, like echo, T-Holter, or a cardiac MRI, coronary angio. These are the questions we get whenever we see such patients with this ECG. So first and foremost thing is we can proceed. The approach to this patient is a patient-centered, patient-tailored. Like depending on the patient's age, patient's demographic status, we need to change accordingly, and accordingly we can select the investigations what we want to order for the patients. So first and foremost, I would like to do an EKG, 12-lead ECG in this patient, because with this 12-lead ECG, so the extra information I get is I can localize the type of ectopics, so that it narrows down the DD, and we can know from where the site of origin of the ectopics. Then we can plan the further treatment, further management strategies, like further investigations in such type of patients. So the next thing is we need to have a complete history, like regarding his symptoms and other daily activities. We need to have a complete history of the patient. And in this patient particularly, he is completely asymptomatic. So this is the common scenario, like a patient is completely asymptomatic, but ECG will be showing some ectopics. So this is one of the common scenarios we come across. Then after having a 12-lead ECG, what are the other investigations we can do in such type of patients is like a 2D echo. So in this patient, the 2D echo is normal, like there is no regional abnormality, or the LV function is normal with a normal LVEF. So then the other investigation we can do is to know the burden of the ectopic burden. See, if you see the ECG, we are seeing approximately 6 ectopics in 10 seconds. So this ECG lead is of 10 seconds. So if you multiply, it comes to around 60,000 PVCs, but that is not the scenario. So we need to exactly know the ectopic burden of this patient. So for that we need to have a Holter. So Holter was done in this patient, which showed a 3% burden of the ectopic, and predominantly patient is in sinus rhythm. So what are the other things? So then what to do? The other investigations are to risk stratify the patient, like we can have a TMT, because and even in ECG we need to search for subtle STT changes or any other changes that are suggestive of ischemia, so that we can plan future further investigations, like TMT. If you give a stress test, so in this patient TMT is negative for an inducible ischemia, and ectopic burden has decreased at the peak succession. And this is one of the good point, like if the ectopic burden has come down on a peak exertion, that means it falls into a low risk strata. So now we have classified, localized the ectopics, probably looks like an RBOT ectopics, and we have stratified the patient to low risk strata. And how do you approach the patient? How do you manage the patient? Whether reassure, beta block, or in radiofrequency ablation, or some antiarrhythmics, or an ICD implantation. Any inputs?
Sir, Kirtika madam, any comments on this, as to how to manage this patient?
So, how do you like to go, sir, with this case?
Basically, he is an asymptomatic 22-year male referred to the OPD with for surgical fitness.
Yes.
Incidentally found out to be having some ectopics, and Holter showed only 3% of the ectopic burden.
For surgical fitness?
For some minor orthopedic surgery, and for
With
that he was referred to the cardiac OPD for fitness, basically.
With my limited experience, what I observed is that these ectopics, they are generally sympathetic mediated, especially pre-surgical, where this ECG is showing around more than 30% load, but Holter is showing only 3% load. And the R wave in lead 2-3 AVF is more taller. That means the focus is somewhere like after localizing, it's above pulmonary valve. So this is a kind of thing that how we do renal denervation for these resistant hypertensions. This is the thing we do, pulmonary denervation. So it's a case where reassurance is sufficient, otherwise we need to go for beta blocker, because most of them are sympathetic mediated. Even a calcium channel blocker can be given, because it also acts at that terminal only. Madam,
Yes, Dr. Kritika has rightly said, we just reassured the patient. After the surgery, maybe because of the stress of that pre-op events and all, he had the ectopics, and once the surgery is over, he is completely free of ectopics and his ECG was completely normal. So this is one scenario we commonly come across. And coming to the second scenario, probably we have dealt with a benign thing. Now this scenario is a malignant thing. Like she is a young 25-year-old male who is 1 month postpartum and admitted in some other hospital with recurrent excessive seizures or loss of consciousness. That record was not particularly sure whether she had seizures or loss of consciousness. And it shows that she doesn't have any similar past history nor any other significant history. And she denies any similar history in this family. But on further questioning, she says that her brother died because of heart attack 2 months before. And pregnancy was uneventful and delivered by an LSCS for obstetric indications. So how do you approach? What are your thoughts when you see a patient, such type of patients? Any comments?
Sir, any comments on how to approach in a 25-year-old postpartum prevented with recurrence episodes of loss of consciousness with a family history of sudden cardiac death? So, what investigation would you like to have next? Sir?
ECG we had to take initially because.
Yes, this was her ECG. Sir, I'll just expand the history also. Initially, she was seen by when she went to ER, they thought that it's maybe she was in a status epilepticus, so she was referred to neurologist and admitted under neurologist care. She was started an anti-epileptic center. It was the ECG at the time of admission. No, sir. Actually, this was her ECGs extracted from the previous reports. These three were the ECGs. Like 1 month prior to admission, these were her ECGs. So I'll show you the ECG at the time of admission. So this is the ECG at the time of admission.
So this is at the time of admission, sir, ECG? Any
Progression is there, prolonged, QT interval is prolonged.
They're telling that prolonged QT interval they have noticed.
Yes, sir. There is a subtle increase in the QT interval, and of course this ECG we can make out what are all the ECGs that I have scanned through in the previous also. Definitely it is showing a prolonged QT, but it is obviously not reflected in the ECG. If you have a simple glance at the ECG, we think that it's a normal ECG, but looking at the QT interval, definitely it is prolonged. So, and the day next to that admission, she continued to be under neurologist care only and continuously having status. And these were the ECGs, 2 ECGs that were taken the next day. It showed ectopics as well as NSVT episodes also. So at that time, cardiologist was called. And so incidentally what happened was while he was doing an echo, patient had that episode again. So at that time he noted a VT, and from there he was referred, that patient was referred to our hospital for further management. So basically these are the investigations what they have done. They have ruled out everything like hypothyroid, dyselectrolytemia, all these things they have worked up. So they have ruled out everything. This was the brief discharge summary that was given. Like she had a VT. We can call it a VT storm. for which they were shocking the patient also, but it could not be reverted. So they also suspected some QT prolongation with a severe LV dysfunction, and at the time they left against medical advice and came to our center, sir. So in our center, so when she landed in the ER, she was very hemodynamically unstable, continues to have VT episodes, and the ECG taken was at that time showed a QT interval of around 580 milliseconds. So she was started on xylocod infusion and oral beta blockers. By day 3, like after 72 hours, her episodes settled. She didn't have any further VT episodes, and following that, maybe on the 3rd day or 4th day, ICD was implanted. After that, she was started on oral mexiletine and oral beta blockers, and she didn't have any VT episodes further. She was discharged in a stable state, and she was done a regular follow-up, like 1 month and 3 months and 6 months. She didn't have any, even the ICD didn't show any VT episodes. But unfortunately, during the COVID days, what happened was mexiletine was not available for 1 year, so she stopped taking mexiletine. Again, she came to the OPD with history of some shocks. So on examination, on device interrogation, it found to be a true shock, committed shocks. So found out to be the patient is having multiple episodes of VT. So again, the patient was started on mexiletine. So this is one of the, and in this MRI was also done to rule out any other structural abnormality of the heart, but MRI was normal. So this is one example where ECG may look normal. We need to be observing. We need to observe the subtle changes that may think of some diagnosis. The next scenario. This is the next scenario where she is a middle-aged woman who came to the OPD with complaints of recurrent episodes of palpitations and SOB on exertion. And she is having these symptoms for the last 2 to 3 years. And of late, there is an increase. She noticed an increase in the severity of the symptoms. So this was her ECG at the time of presentation in the OPD.
So any comments on the ECG, sir? The 30 middle-aged woman with recurrent episodes of palpitations now.
Ventricular trigeminy is there.
Ventricular trigeminy. And regarding the morphology of PVC, sir, any clues we are getting to know?
L3 T inversion is there, and AVF also T inversion is there.
Yeah.
We have to rule out microvalve collapse.
Okay, sir. Yeah.
So ECG was showing multiple ectopics, probably an RVOT ectopics, and incidentally on verifying her previous records, this was her ECG. That means she was admitted in some other hospital probably 6 years back. At that time she was diagnosed as having PSVT, and which reverted with an adenosine. And this was her Holter. This time, on seeing the ECG, we did a Holter, which showed that the ectopic burden to be around 28%. And the patient is very symptomatic. She is even afraid of moving a little bit. So we took her for ablation. So we ablated in that area, and maybe post-ablation, this is her ECG. So we localized it to RVOT area, and we ablated there, and this was her ECG post-ablation. A few points basically. So PVC burden definitely is related to LV function. So the more the PVC is, like if the PVC burden is more than 15%, there are chances that the patient may develop tachycardiomyopathy also. So these things we need to consider for further management of the patients. So this is the last scenario. Again, a middle-aged woman. Actually, she was referred to the OPD for RFA itself, because she has some history of pre-syncopal attacks and giddiness. This was her ECG.
So middle-aged woman was referred for radiofrequency ablation.
As such, the ECG doesn't throw any much light actually, basically because the baseline is not clear in V1. But what you can see is multiple ectopics, probably an RVOT etiology, RVOT origin. So she was evaluated further. Like 2D echo showed a normal LV function. There was definitely the right ventricular hypertrophy with some RV dysfunction. So we thought there could be some structural disease, like we thought it could be an ARVD. So we referred the patient to MRI, cardiac MRI. And meanwhile, other investigations were also done. So Holter was done, which showed an 8% of ectopic burden. Angio was done, normal coronaries. X-ray, there is no obvious abnormality on the X-ray. So this was an MRI report. MRI clearly showed that it's an ARVD. So this is one of the cause. Whenever we see a patient with an RVOT ectopics, one of the cause we need to consider is an ARVD. Unless until we are very sure that the echo is completely normal with the normal chamber dimensions and all, first thing we need to rule out is an ARVD. And this lady has also a neurofibromatosis. But it's an incidental coincidence, but doesn't have any significance. But she also has neurofibromatosis and found out to be ARVD. So how to approach this patient? Because ARVD, generally it's a transmural disease. Like there will be a replacement of the myocardium with a fiber fatty tissue. So subjecting this patient for an ablation will be a riskier procedure. Like we need to do a combined approach, like a both epicardial and endocardial approach. So and also even if you look at the guidelines also, we considered giving her an ICD. So we gave her an ICD. And she was on a regular follow-up, and these were the ECGs on a regular follow-up. So she continued to have the ectopics and also NSVT. Off late she developed NSVTs also even on beta blockers. And one day she landed up in the emergencies with multiple ICD shocks. So device interrogation showed that it committed shocks, so appropriate shocks. So she was taken for VT ablation because there was no other treatment option available. She was on optimal medical management with all the antiarrhythmics and all. Then we did an ablation with both endo and epicardial approach, but fortunately on ablating on the endocardial surface itself, the ectopics disappeared. And for the last 1 year, she didn't have any ICD shocks, and this was the ECG after the ablation. To sum up, whenever you see a patient with ectopics, you need to have complete clinical history of the patients. Like you need to have palpitation, syncope and pre-syncopal history, any family history of SCD, or patient is on any drugs, or at least a caffeine intake. Before taking an ECG, if the patient is on high doses of caffeine, even they can provoke ectopics in some patients. And apart from that, we need to do a detailed physical examination and other tests like ECG, exercise test, Holter and echo. So these are the tests we do, and generally we approach the patient. This is a common approach I follow, an approach to patients with an ectopic. I look whether the patient has a structural heart disease, what is the frequency of the PVCs and the symptoms. So if nothing is there, just reassure. If only frequent symptoms are there in a structurally normal heart with no frequency of frequent PVCs, that beta blockades are enough. And if at all it is a monomorphic frequent PVCs, then catheter ablation is advised. Whereas when the patient has all the three, like a structural heart disease, frequent PVCs and frequent symptoms, we need to risk stratify the SCD, and ICD is the first thing that has to be done. If the patient has a recurrent ICD episodes or continues to have VT and NSVT episodes, then we can give, even on beta blockers, then we can consider taking the patient for catheter ablation. Thank you.
Thank you, sir, for presentation. Sir, most of the times in OPD, in asymptomatic patient, it is common to will see PVCs. So if you ask a question, when to worry about these PVCs?
See, thing is, any PVC we just need to quantify the PVC load. Like we need to do a Holter. Either it can be a 3-day Holter or a 7-day Holter. So if the frequency is too high, like say the study says that if the peak frequency burden is more than 15%, definitely there are chances that patient may develop tachycardiomyopathy. Then we need to worry. And other thing is site of origin of PVC. If it is most of the times RVOT VPCs are benign, but if they are originating from other sides, like from the left side of the heart, then we need to consider other possibilities also. And we need to go back to the ECG and look at any changes for ischemic changes are there in the ECG and all. Then we need to evaluate in that way. Like we need to rule out ischemia also in such type of patients.
Thank you, sir. If there are no further questions, I would like to call upon next speaker, Dr. Nagasri Harita Madam, to continue the remaining part of the syncope and palpitations.
Good evening. This topic is a very small and regarding syncope, which we commonly miss in the OPDs. Most of the times, syncope is missed by ER. Even cardiologists, we do think that it is a vasovagal syncope, reassure the patient, and we will send them home. But the problem is, during reassurance, we will be very confident and we will send them home. But afterwards, we do see that many of the patients have some or other problem which causes this syncope, and they may land up in a deadly complication. So my topic today is just I will show some of the ECGs in the Holter. As in the previous talk, Chandramouli told that ectopics or bradycardia or sinus bradycardia or a heart block, usually it is a dynamic process and we don't see in all the ECGs. So if it is normally the patient may present in a conscious state, but still they may have a problem. One second. This is a wrong slide set that is copied, but still I would just show you the ECGs that are taken. So here is a 62-year-old male patient who came with complaints of dyspnea, palpitation on exertion, and 2 episodes of syncope, hypertensive, non-diabetic. Angio was done 5 years back and was advised medical management. At presentation, he is completely normal. Pulse rate is 95, everything is stable. We did these investigations. And this is the ECG of the patient when he presented to the OP. Echo showed left ventricular hypertrophy without any obstruction, normal LV function, no RWMA. So what is our next plan?
Can you show the ECG again to the audience?
So this is the ECG of the patient.
Sir, any comments on the ECG and left ventricular?
ECG shows sinus rhythm and presence of Q waves in inferior leads place. Any old inferior MI or any scar is there by home.
Echo.
Yes, echo is normal, sir. It is hypertrophic, but not non-obstructive.
So non-obstructive
No
hypertrophic
regional wall
cardiac.
motion abnormality.
Would you do a CT angio?
Sir, angio was done 5 years back, A mild disease was there and he was advised medical management. So these are the options: reassure the patient, send him home, or a neurology consultation. He had 2 episodes of syncope before presentation, and he is having exertional breathlessness. So angio was mild disease was there. We did the angio. This is the Holter monitoring of this patient, which showed a sustained ventricular tachycardia. We can see the broad QRS complexes at a rate of around 180 to 190. So this is the cause of his syncope. So we implanted a defibrillator intracardiac. So this is the second case, 57-year-old male, non-diabetic, presented with giddiness and profuse sweating with 1 episode of loss of consciousness in the early hours. There were no provocative events like a neck collar or a micturition or cough syncope. No provocative events for this patient. Patient came fully conscious to the ER. So his blood pressure was slightly high when he came to the ER, and he was referred for a neurology consultation. This is the presentation ECG of the patient. Echo normal, troponin negative. He was advised observation for 24 hours, but he went, he wanted to go on DAMA. Again in the ER he had sudden giddiness with LOC. He recovered with atropine. This is the ECG of the patient, repeat ECG of the patient during syncope.
Sir, any comments on the ECG?
ECG showing bradyarrhythmia and regular PP intervals and regular RR intervals, probably complete heart block, symptomatic.
Yes, sir. Initially it was a benign ECG with just an RBB, but we could see that here it is a dangerous complete heart block with 3:1 escape rhythm. So angio showed moderate disease. We did permanent pacemaker implantation for this patient. Next case is 75-year-old male patient who came in unresponsive state with a history of chest discomfort for 30 minutes. He was in unconscious state and CPR was started. Monitor showed ventricular fibrillation and he was defibrillated, intubated and connected to a mechanical ventilator, and ROSC was attained. Post ROSC his GCS was 3, and this happened in 2018, and all the hypothermia measures were taken. So in the past history, patient had an old anterior wall MI somewhere around 1999 and had primary PCI at the time in US. So had moderate LV dysfunction. So vitals after resuscitation 68 per minute, 90 by 60 pressure, and this is the ECG post resuscitation, which is almost normal. Even the anterior wall MI changes that were there before, he had an MI, but there is not like a Q in the anterior leads. It is a small R wave with poor R progression was there, with minimal T wave inversions in the lateral leads. So echo showed a dilated LV with an akinetic apex. Severe LV dysfunction was there. Troponin was positive. Discussed with the attenders about the possibility of brain death. So what next? Should we go ahead with any treatment, or should we stop here thinking that it is a brain death case, or what are the options that are left over for the physician?
I think when you initiate a targeted temperature management, I think you take 72 hours to reassess.
I couldn't hear, sir, pardon.
No, I'm saying we have initiated the targeted temperature management, TTM, hypothermia. So
No,
I think we have
it
to
is
wait.
a out of hospital cardiac arrest, sir. He arrested outside. He came with ongoing CPR to the ER.
Okay.
So remote MI, recurrent episodes of...
Brain death is confirmed when?
That is
Possibility is there.
not established, sir. GCS was 3, pupils were dilated. But the attendants were keen for the further management. His son is in US, where he underwent PCI in 1999. So we went ahead with the angiography, post cardiac arrest without ST elevation. Also, we have to go ahead with the coronary angio. We did the coronary angio. There was mild instant restenosis with normal distal flow. So neurologist consultation was taken, MRI done. There were small chronic ischemic changes, but no infarcts. And after treatment, during treatment, actually patient again developed a VT on ventilatory support, deciverted. So as the patient is having recurrent VT and mild improvement in the neurological status, we offered AICD for this patient and did AICD, and he was discharged. So MI, any post-MI patient having a significant scar, large scar after 90 days of MI, having moderate to severe LV dysfunction, we should be very careful and keen. If the patient is having any ventricular tachycardia or ectopics, we should not miss VT in these patients. If the patient complains of syncope, then we should be more alert and go for a Holter and check if there are any NSVT runs in those patients. So this is the last case, 80-year-old male patient post CABG, came for a regular follow-up. He was on beta blockers, aspirin and statin. He came to ER with transient loss of consciousness. So how should we approach? ECG was normal.
Sir, any comments? 80-year-old man, post-CABG with transient loss of consciousness.
Echo.
Echo is normal, madam.
ECG
Normal.
is normal.
Echo normal, ECG normal.
ECG is also normal.
ECG also normal.
Holter analysis.
We did a Holter analysis. Actually, Holter was done by a neurologist and it showed a significant pause. Tachybrady
syndrome.
and patient was on beta blockers. So always whenever we see any pause, we have to see for the causes of, we have to see both the physiological and pathological causes of bradycardia. Physiological causes being epilepsy, pressure on the carotid sinus, vomiting or sudden coughing, bearing down for a bowel movement or post-micturition, and sudden contact with cold water, hypothermia, some of the fevers, pathological being some of the fevers recently, even during COVID, we do see that some of the antivirals used to cause sinus bradycardia. So other things, these are all the list of pathological causes of bradycardia. So first thing we have to exclude before going for a pacemaker is whether the patient is on beta blockers or calcium channel blockers or ivabradine or any bradycardia causing drugs. So these are the indications for sinus node dysfunction and indications for AICD. Post-MI patient, if we see and the ejection fraction is very less, we should be very cautious in those patients even if the NYHA class is 1. Thank you.
Thank you, ma'am, for an elaborating session on various indications of ICD, both primary and secondary. So if there are no further questions, we will conclude this session and we'll move on to the next session. I request Krishna Mohan sir to hand over mementos for the speakers and moderators and panelists. Yeah. Good evening, everybody. Yeah. The next session will be on prevention of DVT and early pickup and management of the pulmonary thromboembolism. So this we would like to discuss with a few case scenarios. The first case being a 38 years male in IT employee. He came with chest discomfort since 2 days, retrosternal burning. So he came to the emergency. So while he was awaiting for the collection of blood samples, had one episode of syncope along with setting and loss of consciousness. So he was moved immediately to the emergency room. In the ER, he had again one more episode of syncope. So past history, he had some congenital heart disease for which surgery was done. At the time of resuscitation, we don't know the details. So here vitals, pulse 110 per minute, BP 110/70, and respiratory rate 26, he was hypoxic. So sorry for the quality of ECG. So this is the ECG. So how to proceed further? A young male with past history of some congenital heart disease presented to the ER with 2 episodes of loss of consciousness, and this is the ECG. Yeah, in ECG we are seeing the T-wave inversions in the anterior leads. So, and the echo is moderately dilated RARV with TR gradient of 54 and severe PAH, and the strop T was positive. Has his initial complaints were chest pain with sweating and trop T positive with ECG showing the anterior lead changes. We went ahead and done the coronary angiogram. Coronary angiogram was absolutely normal. So what next? So then with 2 episodes of syncope and echo is showing moderately dilated RARV with the TR gradient of 54. So there was a suspicion of pulmonary thromboembolism. Yes, sir. With echo showing the RARV dilatation and pulmonary hypertension, we had and did the CT pulmonary angiogram. It's showing multiple defects in the starting from the main pulmonary artery extending into the right and left, extensive pulmonary thromboembolism. So what to do next? This patient presented with syncope and CT showing pulmonary thromboembolism. Should we do thrombolysis for this patient, or should we manage with only with anticoagulation? So this patient comes under high risk pulmonary thromboembolism. Any pulmonary thromboembolism presenting with syncope comes under the high risk category. So we went ahead and did thrombolysis for this patient with 20 mg bolus tenecteplase followed by 5 mg for our infusion for 2 hours. And we have further evaluated the patient, the region for the clot pulmonary thromboembolism, we found to be his homocysteine levels are elevated. And after thrombolysis, he was put on anticoagulation, rivaroxaban, and after thrombolysis, the echo showed decreased TR gradient. And this is the ECG after the echo. So from the case 1, what lessons we have learned is there should be a high index of suspicion in case of pulmonary thromboembolism, because many of the cases they mislead us. They can, initially we will think of an ACS or we will think of any other medical conditions, but high index of suspicion needs to pick up a pulmonary thromboembolism. Coming to the case 2, a 52 years female, diabetic hypertension, again with syncope, examination shows hypotension, hypoxia. So this was the ECG. Yeah. Yeah. Yeah, you have picked it up rightly, sir. It is showing sinus tachycardia. There is an RBBB. There is S1 QT3 pattern. So showing that there is an RV strain. So this is the echo showing the grossly dilated RV and grossly dilated pulmonary artery. You can see RRV dilatation, and there is a TR with pulmonary hypertension. So blood investigations, there was strop was positive and anti-proBNP was 494. And here the trop is positive. There is there is a chance that she might be having a coronary artery disease also. But this patient had an history of knee replacement 4 days back, and pre-surgical CTCA was normal, so our coronary etiology was ruled out. So what is the diagnosis and what investigation has to be done in patient?
Sir, how do we proceed in this case?
So post knee replacement 4 days back, presented with syncope, echo showing RRV dilatation and ECG showing RV strain.
D-dimer, right?
Yes, sir. Sir, here we have a high suspicion of pulmonary thromboembolism. D-dimer has a role in only in low suspicion to rule out the pulmonary thromboembolism.
When we are, what Raja is saying, when we are very suspicious, when we are suspicious of PTE, then that there is a role of D-dimer. But here we are very clear about the anticoagulants.
Yes, sir. We have, anticoagulation. We want to thrombolize this patient without CT.
So, so Raja, how are the hemodynamics? Hemodynamics, what is the BP?
BP was 90/60.
90/60.
And she is hypoxic and...
Sir, CT pulmonary angio has been done and the CT...
Yeah, CT pulmonary angio is done showing thrombosis. CT pulmonary angio has been done and showing...
So what sir is saying is like, why don't we proceed with CTD, catheter-directed thrombolysis?
Catheter-directed thrombolysis has a role only when peripheral thrombolysis has failed. It is only 2B indication, both catheter-directed and surgical thrombectomy. The initial choice will be IV thrombolysis.
So for any case of PTE, so it is the initial systemic thrombolysis is the class 1 indication.
Yes.
So CTD has the secondary role after systemic thrombolysis.
Yeah, if it is refractory to the systemic thrombolysis, then we can go ahead with the intracatheter thrombolysis or surgical thrombectomy.
Okay. So how do we plan for a CTD after systemic thrombolysis? On what parameters do we check for a CTD? Like after how many days or like?
No, if the patient is not responding, hypotension is still there, and RARV dilatation is still there, and if he is still hypoxic, then we have to think about that our systemic thrombolysis has failed, and we have to choose the other alternatives.
Yeah, the right approach is systemic thrombolysis, because if the patient is having hemodynamic compromise.
Yes. Yeah, this patient is in high risk.
What is your drug of choice in such scenarios?
For thrombolysis, sir.
Yeah.
But thrombolysis, sir, our experience, majority of the patient we are doing thrombolysis with tenecteplase only, sir.
Okay.
Tenecteplase only.
Okay.
And this patient we have thrombolyzed with tenecteplase. And this is the post-lysis echo. We can see the RARV dilatation came down, and TR pressures also came down, sir.
Raja, is there any difference in the dose of thrombolysis for what we use for MIs and what we use for PTE?
No, PTE also, it is 0.5 mg per kg body weight if you are using tenecteplase. And streptokinase we have to give, for MI we will give 2.5 lakhs initially. For thrombolysis of PTE we will give 1.5 to 2.5 lakhs we will give. And we have to start infusion 1 lakhs per hour, usually for 24 hours. But if the patient is still showing the signs of RRV dilatation and the pulmonary pressures are not coming down, still hypoxic, we can continue for 48 hours also, still the pulmonary pressures came down.
Yeah.
So this is case 3, I will go fast. It's an 18-year-old male, no comorbidities, presented with class 4 dyspnea, again hypoxic. This is the ECG, again showing a sinus tachycardia. So it's a tropic 17 and anti-proBNP 3650. So this is the echo. Again showing RRV dilatations with severe pulmonary arterial hypertension. So this is the CT showing thrombosis in both right and left. The main purpose of showing this cases is an 18-year-old male with no predisposing factors, directly presented with the class 4 dyspnea. So this is also a PTE, but he is hemodynamically stable. So whenever the patient is hemodynamically stable, he comes under intermediate risk. Again in intermediate risk, if there is an RV dysfunction and TROP and BNP were positive, they will come under intermediate high risk. So in these patients also, we have to do thrombolysis. So both for high risk patient and intermediate high risk patient, that is with hemodynamically stable but with RV dysfunction and BNP should be positive. Then the patient will comes under intermediate high risk, then we have to thrombolyze this patient. So we have thrombolyzed this patient again with tenecteplase, and this is the post thrombolysis echo. So the RA and RV size decrease along with the pulmonary pressures. And we investigated further this patient, 18-year-old boy, why should he develop pulmonary thromboembolism with no significant risk factors. We have sent a coagulation profile in this patient, and we found this patient is positive for factor V laden mutation.
Raja, how could be the timelines for assessing the echo? Like post thrombolysis, when should we check? Like what are the timelines for checking the echo parameters?
Yeah, ideally after thrombolysis we'll check around 6 hours.
6 hours.
6 hours we should check. The pulmonary pressure should came down. If you are thrombolyting with the tenecteplase, so we should check at the end of the 6 hours. If still the pulmonary pressures are not coming down, we should think of continuing the dose if you are giving the streptokinase to extend the infusion.
So the improvement can be as early as 6 hours?
Yeah. Case for 41 years male, again with dyspnea, ECG showing sinus tachycardia, echo RV dilatation, D-dimer positive. So this patient had a history of DVT 4 years back. Again now there is a recurrence of DVT, and now he presented with pulmonary thromboembolism. So the main purpose of showing this case is that past history of DVT carries very high risk for the recurrent episode. So we have a factors, strong factors, moderate factors and weak factors. If the patient had previous history of VTE, then there is a high degree of suspicion whenever the patient presenting with an breathlessness to the casualty. So brief discussion about pulmonary thromboembolism. So in the pulmonary thromboembolism, mainly as soon as the patient present, mainly we have to classify and risk stratify the patient into whether he is coming into high risk or intermediate risk or low risk, and we have to individualize the therapy for acute pulmonary embolism for the mortality benefit. And the second, we have to draw the lines for optimal duration of anticoagulation and selection of optimal anticoagulation. So many patients after pulmonary thromboembolism post-discharge, they will be keep on asking how long should I take the anticoagulation and what anticoagulant is better. And the fourth important question is how to prevent this venous thromboembolism. So in the case 2 scenario, we have seen post-knee replacement presented with the pulmonary thromboembolism. So could this have been prevented? She came for a surgery, relatively asymptomatic normal patient previously, so she developed after knee replacement. So could this have been prevented? So for the classification, there is a difference between European and American Heart Association. Europeans, as I told before, they will classify into high risk, intermediate low risk and low risk. High risk, hemodynamically unstable patient, intermediate high risk, hemodynamically stable but with RV dysfunction and trope and BNP positive, intermediate low risk, normal BP, RV dysfunction, but trope and BNP will be negative. Low risk, no RV dysfunction and hemodynamically stable. Whereas American Heart Association, there is the intermediate high risk and low risk, they will treat as submassive embolism, and high risk they will call it as massive, and low risk being the stain. So what is the therapy? So like in our first 2 cases, high risk pulmonary thromboembolism, we have to start anticoagulation with UFH without any delay, and systemic thromboembolysis is strongly recommended. In intermediate or low risk pulmonary thromboembolism, the initiation of anticoagulation is same, but the thrombolysis, there is a rescue thrombolytic therapy should be recommended with the patient with hemodynamic deterioration on anticoagulation therapy. So high risk and intermediate high risk, we can straight away go for thrombolysis. Intermediate low risk, wait, give anticoagulation, watch for hemodynamic deterioration. If only patients start deteriorating hemodynamics, go for the thrombolysis. Any comments on this then?
Raja, when we want to do workup for this coagulopathies, what are the proper timelines?
No, there is a lot of controversy, because once you start the anticoagulation, the coagulation factors will be consumed. So better to take the blood sample before we are giving any heparin or warfarin dose to collect for the coagulation profile, and then only to start. So when you are about to give the thrombolytic agent or an anticoagulation, draw the blood samples for protein C, protein S, factor V laden, antithrombin T, and then only give the anticoagulation. So this is how we approach acute PE. First anticoagulant, see the hemodynamic instability. With the hemodynamical instability, the high risk, straight away go for thrombolytic therapy. If they are hemodynamically stable, check the RV function and troponin T and BNP. If they both are positive, intermediate high risk, first thrombolyze, negative, monitor, anticoagulant, hemodynamic deterioration, thrombolyze. The next important question, what is the optimal duration of anticoagulation and what is the selection of anticoagulation? Yeah. So ideally, therapeutic anticoagulation greater than 3 months is recommended in all the patients with PE. So who are the subset of patient where anticoagulation can be discontinued after the 3 months? So for patient with the first PE or VT, secondary to major transient or reversible factor. So if there is a clear precipitating factor for pulmonary thromboembolism, like a patient with a knee surgery, we know there is a clear precipitating factor. So these patients, we can stop anticoagulation after 3 months, although a small subset of patients will recover. So who are the patient in whom extensive anticoagulation beyond 3 months is recommended? So oral coagulation of indefinite duration is recommended in patient presenting with recurrent VTE. Like the fourth case we have seen, he has initial DVT plus or minus PE, but second time he again presenting with DVT and PE. So these are the subsets of patient where we have to continue anticoagulation beyond 3 months. Again, any patient with antiphospholipid antibody syndrome, we have to give vitamin K anticoagulant for indefinite period. So patient in whom extension of anticoagulation is beyond 3 months should be continued, although there are class 2A indication. So patient with no identifiable risk factor, like our fourth case scenario, and if there persisted risk factor other than phospholipid antibody syndrome, we have to consider for giving extensive anticoagulation. Likewise, patient with active cancer, also we have to give the lifelong anticoagulation, ideally with low molecular weight heparin or edoxaban. Coming to the last question, how to prevent this pulmonary thromboembolism in hospital scenario? So many patients are admitting with us both medical conditions and surgical conditions. So as soon as the patient admitted with any condition, we have to risk stratify the patient for pulmonary thromboembolism. So for medically admitted patient, we have score called PADA score, and for surgical patient, we have score called Caprini score. So calculate the score and risk stratify, and depending on the risk, we have to we have to state our pulmonary thromboembolism prophylaxis. Suppose the patient is very low risk, then no specific prophylaxis, early ambulation is required. If the patient is having moderate risk, low risk, then mechanical prophylaxis like intermittent pneumatic compressions or compressions can be given. If the patient is having moderate risk, start the medical prophylaxis like low molecular weight heparin. If the patient has high bleeding risk, we can give the mechanical prophylaxis. If the patient has high risk, there is no role for mechanical prophylaxis. We have to go for the pharmacological prophylaxis. So what drugs we have to give? These are the regimens to prevent the venous thromboembolism. So hospitalized with medical conditions, we can give 5,000 units subcutaneous unfractionated heparin or enoxaparin 40 mg low molecular weight heparin with subcutaneous OD. The patient admitted for general surgery, ideal unfractionated heparin or enoxaparin, and major orthopedic surgery, we can choose any one of the enoxaparin or fondaparinux or rivaroxaban. Other thing is when to start this prophylaxis for the patient and how long we have to continue. What is the duration of pharmacological prophylaxis? So for the patient, if you are using low molecular weight heparin, start 6 to 12 hours after surgery. If you are using fondaparinux, 6 hours after the surgery. For rivaroxaban, 6 to 10 hours. For dabigatran, 1 to 4 hours after surgery. Suppose if the patient has very high risk for pulmonary thromboembolism, some of the guidelines recommend that we can start even before the surgery. 12 hours before the surgery, we can give a shot of low molecular weight heparin. And usually our practice is to continue the heparin. If you are giving heparin, continue the heparin till the patient was discharged from the hospital.
Raja, what is your NOACs of choice for long-term prophylaxis of DVT?
Yeah, any of the NOACs like rivaroxaban or apixaban we can give. Suppose if the patient is having cancer, active cancer, for long-term prophylaxis, edoxaban is better. Otherwise, rivaroxaban and apixaban, they are extensively studied in VT prophylaxis.
Okay, thank you.
So this subcutaneous heparin we have to continue till the patient was discharged. But we have seen patient after being discharged from the hospital who underwent knee surgery and hip surgery, they are having the episodes of pulmonary thromboembolism. So some of the patient, they require extensive prophylaxis beyond 28 days also. If the patient is having cancer surgery involving the abdomen and pelvis, and if the patient is having total hip replacement or knee replacement, we have to give minimum of 10 to 14 days of pharmacological prophylaxis. So this is our study. So this 1 year data in our hospital. So we have around 53 patients of pulmonary thromboembolism we have picked up, and most of them are intermediate high risk and high risk. And our thrombolytic agent of choice is tenecteplase, and more than 96% were discharged in stable conditions with mortality of around only 3.77%. So in summary, there is a high risk of suspicion is needed to diagnose PE because it will simulate many other medical conditions and surgical conditions. Early risk stratification and treatment will prevent mortality, and appropriate duration of anticoagulation should be given to prevent recurrence, and venous thromboembolic prophylaxis should be considered for admitted all medically ill patients and surgical patients. Thank you.
Thank you. So I would like to call upon Ramarao Garu to discuss on stoppage of antiplatelets and anticoagulants, crucial decision in non-cardiac surgery.
Respected seniors, dear colleagues, good evening everybody. So this is the problem we are facing daily. So we will do angioplasties and valve replacement. Afterwards, patient will go for some surgeries and all these things. Then in that scenarios, when to stop the antiplatelets and anticoagulants, we will discuss regarding the case scenarios. This is the case one. He is a 60 years male, known case of atrial fibrillation, and he is a known case of CAD triple vessel disease. He underwent PCI to RCA and LCX in 2015. Now he came with frequent urination. Patient was seen by urologist and he advised TURP surgery. So patient was on dabigatran 150 milligrams twice daily and Plavix 75 milligram once daily and rosuvastatin 10 milligram once daily. And ECG suggestive of atrial fibrillation with controlled ventricular rate, and echo is no RWMA with normal LV systolic function. Now,
sir, what could be the next plan in this patient? The patient is on dabigatran and Plavix, planned for a TURP procedure. So how should we proceed in this case? Yeah, TUR, TURP.
PCI was done 4 years back.
PCI was done in 2015 for RC and LCX, and the patient is on dabigatran for AF. So what could be the best plan of action for him? Yeah. Plavix have to be stopped for 3 days before the procedure? Yeah. 3 to 5 days, depending upon the complexity of the procedure.
Dabigatran?
Sir, dabigatran, about the dabigatran? 3 days.
So, as per the guidelines, you can stop clopidogrels 3 to 5 days before the surgery, but when you come to dabigatran, if it is a low risk for bleeding, we can stop just 24 hours before the surgery, and if it is a high risk for bleeding, you can stop up to 48 hours.
48.
So, in this case, we have stopped same thing, and dabigatran again we have started within 24 hours, and Plavix was started after 48 hours. Now come to case 2 scenario. So he is a 82 years male, known case of CAD WSL disease. He underwent to PCI to LAD in December 2021. In the January 2022, he had a history of fall and he had a left femur fracture. So he was seen by orthopedician and he advised for ortho surgery under regional anesthesia. Now ECG and echo was fairly normal. So as the patient underwent PCI just 1 month ago itself, patient is already on dual antiplatelets with rosuvastatin. Now how to approach in this case? Because the patient is just only 1 month 5 days only. It was PCA was underwent.
So, patient has undergone PCA for a stable reason, or was there any ACS?
No ACS. It is
No,
only
it
stable.
was
CA.
only for the stable. So, the complexity of the procedure during that time was like rota used, or the larger stents were placed, or dual stents were placed.
No, single stent only, and
So
it
it was
was
a
a
simple
30 mm stent, which was a drug-eluting stent only.
Okay. Sir, how do we proceed in this case? It was like for a chronic stable angina, PCA to LAD was done 1 month back, and the patient is now on aspirin and Plavix and had a fall. So how to manage the patient just like 4 weeks from the procedure? How should we go? Should we stop both the drugs, or can we put him on aspirin for the to prevent any ST, stent thrombosis? Yeah. So sir's idea is to put on unfractionated heparin and stop antiplatelet drugs and go for the procedure.
Both antiplatelets.
Yeah, both the antiplatelets.
But guidelines are what's saying is we can stop clopidogrel for 3 to 5 days before the surgery, and but no need to stop the ecosprin. At least we can 75 milligrams once daily we can continue. And in this case we have started a Clexin for the purpose of DVT prophylaxis, not for the bridging therapy. Sir?
Sir is asking which is the better one?
Which is better? Is it Clexane or unfractionated heparin? So,
So
I think
anything,
unfraction-
see, there is not much difference. So you can give anything. For DVT prophylaxis, I feel Clexane could be a better option.
So, Ramaragar, why the aspirin? Like, will there be any excess bleeding complications for like a femoral procedure? Like,
But still guidelines are saying the bleeding with the ecosprin you can control with manual compressions, with clamping and all these things. So most of the procedure, unless you are going to deal with very highly vascular organs and all these things only, you should stop. Otherwise, no need to stop the ecosprin.
so for the organic procedures inside, like we have to stop aspirin, and for other.
intestines, liver, when you are manipulating, in that condition only you can stop the ecosprin. Like femur and all these things, no need to stop the ecosprin.
So it is safe to go on aspirin.
Yes, with the
For
ecosprin.
orthopedic procedures.
Yes.
Yeah.
So he intervened with along with the ecosprin, he intervened safely. So post-operatively, he was started on ecosprin 75 mg within 24 hours. Already is continuing, and Clexane was started again after for 3 days, and the Plavix, sorry, here it.
Aspirin.
Plavix was started after 3 days after the surgery. So this is a third case. So 39 years female. She is a known case of rheumatic heart disease and status post MVR 2 years ago with the TTK Chitraval. Now came with excessive vaginal bleeding, and a case was seen by gynecologist, and she advised for vaginal hysterectomy along with bilateral salpingo-oophorectomy. So ECG and echo was fairly normal, and there was no AF in the ECG. So patient was on ecosprin 75 milligram, acetram 1 milligram, and 1 and 2 on alternate dates, and Frusilac off tablet once daily. Now, in this case, how to approach?
So stop the anticoagulant for 2 days and put on unfractionated heparin and get to.
What sir telling is exactly correct. So any prosthesis in the mitral valve is a very high risk for thromboembolic risk. So this is the scenario where definitely mandatory bridging is required. So bridging is nothing but replacing long-acting anticoagulants with short-acting anticoagulants like heparin or low molecular weight heparin like Clexane. Okay.
Sir, here what is the choice between unfractionated heparin and low molecular weight?
No,
Like-
only half-life is different, but action is both of them are similar only most of the times. So there is not much difference. So heparin you can stop just 6 hours
Sir,
before the
with
surgery.
respect to the valves, sir, with respect to the valves, we have an opinion that there is a little more thrombosis with the unfractionated one compared to, with the low molecular weights when compared to the unfractionated one. Is that true? Like, with respect to the artificial valves, unfractionated will be better than low molecular weight.
I don't think so.
Yeah.
So, in this case, both acetram and ecosprin stopped 3 days before the surgery, and Clexane 60 milligram subcutaneous BAD was started, and 12 hours before the surgery, Clexane was stopped, and we need to check the PTNR just before the surgery, and it was normal in this case. So, again, Clexane was started within 24 hours of the surgery, and ecosprin after 3 days, and after 3 days, acetram was started, and once INR target was achieved, then Clexane was withdrawn. So what the guidelines are saying about this? So I will briefly discuss about the guidelines. So when patient is on anticoagulants like acetram and warfarin, acetram will have long acting compared to warfarin. So off-life is 5 days, whereas warfarin it is 3 days. So when patient is on acetram, better to stop for 5 days, whereas for warf it is just for 3 days is enough. And again, if you want to start this same thing, you can start after the surgery. And most of the studies saying is, unless otherwise very high risk for thromboembolism, no need for bridging. So, especially with when you take the direct oral anticoagulants, so we have to divide the surgeries into 2 categories. Whether it is the surgery is a low risk for bleeding or high risk for bleeding. Suppose if the surgery is low risk for bleeding, just 24 hours stopping of the direct oral anticoagulant is enough. Suppose if it is high risk bleeding, then we need to stop for 2 days. So, and within 1 day itself with low risk for bleeding, we can start the direct oral anticoagulants, and after 2 days, if it is a high risk for bleeding. So coming to antiplatelets, so if the patient is on prasugrel, we need to stop for 7 days. If the patient is on clopidogrel, we need to stop for 5 days, whereas for ticagrelor, for 3 days stopping is enough. And we have to restart within the 24 to 48 hours. So whenever the patient comes, these are the guidelines, but we have to completely evaluate the patient. What is the thromboembolic risk? What is the bleeding risk? And what is the type of surgery it is going on? So all these things we have to consider, and then only we have to take the decision. So first we have to see the thromboembolic risk, then the bleeding risk, then whether it requires interruption of the anticoagulations or not. And the final thing is whether bridging is required or not. So, thromboembolism is very high in cases like ongoing atrial fibrillation, prosthetic heart valves, especially placed in mitral valve, and recent history of thromboembolism if it is less than 3 months. And if it is a Chadwick, if the patient is having AF with Chadwick score of greater than or equal to 6, then it is also have high risk for thromboembolism. Similarly, if the patient is having more number of prosthetic valves or prosthetic valve in mitral valve or prosthetic valve in aortic valve also, like cage and ball and tilting disc valve, they will have high risk for thromboembolism and other comorbidities. If the patient is having CHF, atrial fibrillation, all these things will carry the high risk for thromboembolism. In these cases, we have to see. So this is the table it is showing. So thromboembolism risk. Suppose in patient is having atrial fibrillation, if Chadwick score 2 to 3, it will carry low risk for thromboembolism. 4 to 5 is a moderate risk, and if it is greater than or equal to 6, it is a high risk. Coming to prosthetic valve, bileaflet aortic valve prosthetic is a low risk for thromboembolism. Similarly, bileaflet aortic valve in aortic valve with comorbidities like age greater than 75 years, CHF, AF or previous history of stroke, it will become the moderate risk. Similarly, high risk is any prosthesis in the mitral valve or aortic prosthesis like cage valve or tilting disc will become the high risk for thromboembolism. Similarly, when come to venous thromboembolism, if it is more than 12 months, it is a low risk. 3 to 12 months is a medium risk, and if it is less than 3 months, it is a high risk for thromboembolism. So again, we need to see the surgery, type of surgery, whether it is a low risk for bleeding or high risk for bleeding. Suppose if it is a low risk for bleeding, generally no need to stop the antiplatelets and anticoagulants. Depending on the surgery, we need to see, like minor dental procedures or cataract removal, joint injections, diagnostic endoscopy, laparoscopic cholecystectomy, carpal tunnel repair, bronchoscopy, or abdominal hernia, like these conditions. So we can stop antiplatelets, anticoagulants, very short duration, or we can continue also.
Ramarao garu, we have a generally we have a common scenario of rheumatic valve patients post MVR or AVR having a small dental procedures like tooth extraction. So tooth extraction, which is a normal day procedure. So what about in these cases? So is it not necessary to stop anticoagulants for the procedure, or can we continue?
We have to check the PTINR. If it is in the therapeutic range, generally we can proceed without interruption of the anticoagulations if the patient is having prosthesis in mitral valve.
Yeah.
Yeah.
So it's not necessary to stop anticoagulants.
Or if you feel still bleeding risk is high, then we need to bridge the therapy with anticoagulations like Clexane or heparin, and we need to stop just 12 hours or 6 hours before the surgery, and immediately within 6 hours after the surgery we can restart it. But when you come for high-risk surgical procedures, here we need to stop at least 24 to 48 hours. So in these cases, then bridging is mandatory. Thank you.
I request Srinivas Rao sir to hand over the gifts to the panel members.